فيلم ريدنج سيشن برضو، وهنرفعه على الويب سايت بتاعي على اليوتيوب، بحيث ان اي حد ممكن يستفيد منه بعد كده. دلوقتي احنا نبتدي الحالات، والدكتور شريف هينسق مع حضراتكم ازاي نعمل الإجابة، وبعد كده أنا هكومنت تعليق بسيط على الإجابة إن شاء الله. ديت أول حالة، وأي حد عاوز يشارك يجاوب يعني بإذن الله.
دكتور ممدوح، هستأذن حضرتك بس نقول لهم كله يعمل ميوت، اللي هيجاوب يعمل انميوت لنفسه عشان الأصوات بتتداخل مع بعض.
طيب يا جماعة الخير، كلكم تعملوا ميوت، واللي عاوز يجاوب بس هو اللي يفتح الصوت ويجاوب، عشان الأصوات ما تتدخلش مع بعضها، وفي نفس الوقت نقدر نستفيد كلنا.
أبدأ.
اتفضل.
CT brain basal artery thrombosis.
ممتاز. And this is the right answer, the CT brain. طبعا احنا عاوزين نخلي بالنا مش كل بذل ارتري بيكون مبيض كده شويه، لان هو ثرومبوز. لازم الكلينيكال بتاع المريض يبقى بيسمح بهذا، لان البذل ارتري ثرومبوزس حاجه مش سهله قوي، وفي نفس الوقت لابد ليها من كلينيكال داتا مهم. اتفضل.
أنا عشان عندي محاضرة
يا شيماء.
في ريز هاند الدكتور حاتم عاوز يجاوب؟
اتفضل.
multiple السلام عليكم ورحمة الله. multiple study of MRI axial T1 post contrast flare and coronal. I think this is post contrast also. By axial there is ring enhancement seen in the post contrast. Flare, there is evidence of edema noted exactly at the body of the caudate nucleus, right side, with compression of the lateral ventricle. Ring, this is differential diagnosis of ring enhancement with edema. There is, we should compare with the history. First of all, we should also compare with the diffusion to exclude the abscess.
Can you see this history?
Yeah, I saw.
Then what do you think?
I think that this is herpes.
Yeah. This is the HIV virus.
Or lymphoma. Lymphoma. This is a typical lymphoma.
You know that the two main differential diagnoses in patients with AIDS are the
toxoplasmosis and lymphoma.
And the lymphoma. And remember that I have mentioned many times in my lectures that this appearance and this site is almost a classic site for toxoplasm. Then many times we are not able to differentiate between toxoplasm and the lymphoma unless we have the biopsy. But if you see this particular lesion in this particular situation with this particular enhancement, you may suspect the possibility of toxoplasm. Then the next case.
Can I comment?
Yes, please.
Yeah. Evidence of cystic lesion noted in the Indian cistern, right side. Also, we saw there is evidence of restriction My suggestion, this is epidermoid cyst.
No, this is not. This is the ADC map, and
ADC.
this is this is flare, and this is T2, and in the flare you see.
So it is arachnoid. Arachnoid.
Okay, this is arachnoid cyst. Next.
أبدأ؟
Yeah.
MRI brain child shows right intraventricular mass lesion.
Yes.
Hyperdense. Oh, sorry. Hyper.
And this is T2, and this is enhancement.
This yes. It's pilocytic astrocytoma. It's cyst with nodule.
That this is intraventricular.
Sorry. Reflexes meaning
the plexus papilloma.
post contrast is homogeneous. I think it's meningioma.
Wait.
Plexus papilloma.
Child.
And you see this very characteristic appearance of the contour of the lesion. And here you see the very like or the lobulated appearance with an intraventricular mass in a pediatric age group.
Arachnoid papilloma.
Yes, choroid plexus.
Papilloma. Choroid plexus papilloma.
Okay. Next case.
Perivascular spaces.
Yes, and these are the CSF-like cystic structures in the high frontoparietal area are classic for Virchow-Robbins spaces or dilated perivascular spaces. I presented this case here and in order not to misinterpret these lesions for MS plaques or any other pathology, because the Virchow-Robbins spaces, sometimes they are so prominent that you can mistake these lesions for any other pathology, but be careful about this. Okay, next. Yes, then this is a borencephalic cyst with this flare. The cyst is communicating with the ventricle, and it shows low signal, meaning that it is of CSF signal content.
City brain extradural hematoma.
Very good. And yes, this is a epidural blood. And one of the criteria of epidural blood is that it crosses the midline, and you know that the epidural space is communicating with each other, but the subdural space is not.
This is right cerebellopontine angle lesion. Show iso-intense in flare, lobulated margin.
Yes.
We should compare with diffusion. This is epidermoid and cerebellopontine angle.
Yes, it is epidermoid because of number one, its signal is not signal of CSF. Number two, it has a lobulated outline, and this is one of the best criteria for the epidermoid cyst. Yes.
This is cystic lesion in frontoparietal lobe with perifocal edema with REM enhancement. And this is the diffusion, the last one?
Yes, this is diffusion.
So it is abscesses with better cyst.
Yes, and this is a classic appearance of the abscess with low signal wall in the T2 weighted image, and marginal enhancement and diffusion restriction of its contents.
Right cerebellar pilocytic astrocytoma.
Very good. This is juvenile pilocytic astrocytoma with internal hemorrhage. And you remember that I have mentioned that one of the criteria of astrocytoma is it may contain blood or may contain of the contrast
Contrast.
material that has diffused into the tumor itself, and this will mask the enhancing mural nodule. Then
Acute infarction, territory right middle cerebral artery.
Mumtaz. And this is acute or let us say hyperacute infarction. This is the hyperdense middle cerebral artery sign with some brightness in the T2 weighted image, and also you got diffusion restriction. This is the hyperacute infarction.
Evidence of post-contrast show leptomeningeal enhancement. Also, we saw frontal ring enhancement with perifocal edema. This is meningitis with the brain abscess.
And there is also one additional finding.
Meningitis and abscess.
Also, still there is one find.
There is a ventriculitis also.
Yes, and there is enhancement of the wall of the ventricles on both sides, and this is ventriculitis. Okay.
Glioblastoma multiforme.
The glioblastoma multiforme will appear bright in the T2 weighted image. Okay, and if you see very dark lesion in the T2 weighted image, then go to the T1. If the lesion is of intermediate signal, then you think of hemorrhage, and this is this hemorrhage. But if you go to the enhancement, the hemorrhage do not enhance, but this lesion is enhancing, and the rest of the scan showed the presence of a similar lesion in the parietal lobe, and this was metastatic deposits, hemorrhagic metastatic deposits.
This is MS, incomplete ring enhancement.
Yes, very good. This is ineffective MS, the big MS plaques with characteristic horseshoe enhancement or incomplete ring sign.
Hydatid cyst.
Yes, and this is hydatid cyst, calcified hydatid cyst.
Arachnoid cyst.
Yes, and this is actually, it simulates an arachnoid cyst, but it is present in a classic position, which is the site of the velum interpositum, which is the recess passing above the third ventricle. Then, if you see a triangular SF containing lesion in the region of the quadrigeminal cistern, then you think of this cavum velum interpositum, and this cyst is a simple cyst present in the anterior or superior aspect of the quadrigeminal cistern, and it shows very similar signal intensity to the CLF with no enhancement, and it does not extend anteriorly to reach the foramina of Monroe. This is one of the classic criteria. Sometimes this lesion contains the laboratory material and may appear somewhat bright, as you can see here, but it will not show contrast enhancement, and will not show diffusion restriction.
It's look like a colloid cyst.
Yes, but this is not the classic
The place. Yes.
Yeah.
Doctor, if it is opened anteriorly, it is cavum septum pellucidum?
Yes,
between
it is
the
continuous between the frontal horns of the ventricles. We consider cavum septum verge and pellucidum.
it is different.
Yeah.
Okay.
Cyst. Colloid cyst.
No.
This is pineal region.
This is
mass.
region in the pineal body, and it is
Pineal teratoma.
This is the before contrast, and this is after contrast, and you may have some of the MR images as well.
Pineal cyst. Pineal cyst.
It is not a simple cyst because there is an enhancing
Nodule.
Yeah. Yes, and this was biologic astrocytoma in the pineal body.
This is BXA.
No.
Cysticercosis.
Yes, and this is
classic appearance of
dot and cyst. Dot and cyst.
Yes, the cyst and the dot sign with some edema around the lesion. This is neurocysticercosis.
Tuberous sclerosis. With giant cell astrocytoma.
Yes, tuberous sclerosis and the giant cell
subependymal astrocytoma.
Very good.
Oligodendroglioma.
And then this is one of the criteria is the linear pattern of calcification, which is typical for oligodendroglioma. Some mass effect exerted by the lesion.
This is subarachnoid hemorrhage.
And this is subarachnoid hemorrhage.
No intervention.
Epidural hematoma. Abscess. Epidural abscess. Empyema, exactly.
And then we think that this is epidural or
hygroma.
No, hygroma do not enhance with contrast. And you see, this is
marginal enhancement.
Empyema and
epidural or subdural.
epidural. It's epidural, subdural. Subdural.
Because epidural empyema is restricted by the meninges and fissures. It cannot reach this huge size and extension. Whenever you see a hematoma or a pus collection which has an extensive distribution over the cerebral hemisphere, and you think of subdural location rather than epidural. And if this collection has extended into the falx, then you are sure that this is a subdural.
Cystic lesion in the left
left cerebellopontine.
It's arachnoid. No, it's extended to the arachnoids.
Yes, this is arachnoid.
Free diffusion.
These are the diffusion.
Arachnoid.
This is there is no restriction, and this is arachnoid.
Free diffusion arachnoid cyst.
Yes, arachnoid cyst can occur at the cerebellopontine angle, and it has a smooth outline and shows low signal in the FLAIR images with no diffusion restriction. It does not show calcium in the wall, and it also will not enhance if you inject the contrast material.
Glioblastoma
multiforme. It's irregular growth
because of the enhancement and the mass effect.
Yes. Eczema. No, eczema. No, it's effacement للسلكاين white matter.
Rupture of the, I think rupture of the dermoid cyst.
Where is the dermoid cyst?
In the third ventricle.
This is fat. Yes, you are right. This is fat. There is no dermoid cyst, and this is the anatomic location of the corpus callosum. Then this is lipoma of the corpus callosum. Okay.
Subacute.
No, it's not that.
This is
infiltrating glioma. No enhancement.
subacute epidural hematoma. Subdural hematoma.
Yes,
Subdural hematoma.
You know, the presence of the pus in the subdural space may irritate the vessels and lead to some thrombotic effect on the veins, and this will result and sometimes in ischemic changes in the adjacent brain tissue.
عفوا دكتور، ليش بس عفوا ممكن نرجع بصورة، ليش قلنا إنه هو سبديورا ما قلناش إنه هو intracerebral إنويما؟
No, I'm talking about this collection. But, this is ischemic brain.
This one?
Okay. Actually, this is the answer is evident here, and I mean by this case to present one of the commonly seen abnormalities in clinical practice, which is known as limbic encephalitis. This limbic encephalitis means that you got abnormal signal in the limbic system or the region of the hippocampus and the amygdala, and this signal is bright in the T2 and the FLAIR with diffusion restriction. It simulates the appearance of mesial temporal sclerosis, but there are many differences. Number one is the presence of diffusion restriction, and number two is the bilaterality and the symmetrical appearance. This means that there is an inflammation of the limbic system, which may be due to a lot of causes. It is not a disease, but it is, as they said, an autoimmune reaction or something like this. This is the limbic system, and if you would like to see this very short video, it explains very good the
Welcome to 2 Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the limbic system. The word limbic comes from the Latin limbus, which means border, and the limbic system was given this name because its structures lie along a horseshoe-shaped area of cortex that appears to be a border between the cerebral cortex and the subcortical structures of the diencephalon. There are many processes associated with the limbic system, but the system is most frequently linked to emotion. There is no consensus on the structures that are considered a part of the limbic system, and some argue that it is too much of a simplification to consider something as complex as emotion to be handled by one group of brain structures.
دكتور ممدوح هو الفيديو ما ظهرش عندنا.
The amygdala is an
هل هو شغال عند حضرتك؟
found in the temporal.
شغال بس مش مشكلة، خلاص خلينا نكمل كده أحسن عشان الوقت تقريبا هيخلص.
خد 10 دقايق.
طيب أوكي. يلا يا شباب الأمة.
Ventriculitis.
Yes, this is the brain abscess that has ruptured in the ventricle, resulting in ventriculitis, and this is also one of the known complications of cerebral abscesses. And this is a glioma because you have a decrease in the N-acetyl aspartate and the considerable increase in the choline, and because of its diffuse character, you may suspect the possibility of gliomatosis.
PVM?
No. Actually, you see calcium in the CT scan. This is without contrast, and calcium also in MRI. This calcium is predominant. Sorry, is
Is it ganglia calcification?
No, it is located outside the brain, mainly in the supracellular system. Then whenever you see calcium outside the brain, think of meningitis. And the most common form of meningitis which will calcify, that is tuberculous meningitis. And this was a multiple tuberculosis in the extraaxial CSF space, and you got some edema around the lesions.
Subdural hematoma on the left side.
Yes, and this is subacute subdural hematoma. The brain is atrophic. There are multiple areas of cystic encephalomalacia, together with a big collection overlying the surface of the brain and displacing the brain tissue inside. Okay.
Hydatid cyst.
Yes, this is hydatid cyst, typical appearance with a big cystic lesion and the internal daughter cysts. Sorry.
Meningitis.
Okay, and you see here that there is diffuse meningeal thickening and the enhancement, and this may require a lot of diagnosis. Either it may be an inflammatory or maybe a neoplastic. And you remember, I have mentioned this many times, in cases of neoplasm, think of lymphoma and metastasis. And in cases of inflammation, think of TB and sarcoid. But if you look here for the coronal images, and you see what looks like a mass in the meninges, and the history of this patient is that she had the breast cancer, then you know that this yes, pleural metastasis.
Metastasis. Metastasis.
Hemangiopericytoma.
Yes, very. This is important. For metastasis in the calvarium, there should be almost equal distribution of the lesion on both sides of the calvarium. But here, the most of the lesion is intracranial, and it has invaded the calvarium and with extracranial extension. And you know that the meningioma and the hemangiopericytoma are included in the same category in the SSD classification. Then you may say a typical meningioma, and you may say grade 2 meningioma, or you may say hemangiopericytoma. All are considered right.
Meningioma with cystic.
Yes, this is meningioma with cystic component, and you see the dural base lesion with enhancement, and you may appreciate some of the dural tail.
Meningitis.
Yes, once again, and you got localized dural thickening and enhancement, you think of infection or tumor. In the infection, TB or sarcoid, and the tumor metastasis or lymphoma. And this patient was having a vaginal granulomatosis, and this is also granulomatous lesion, like TB and sarcoid can affect the meninges, but you cannot reach the diagnosis unless you know the history.
Encephalitis.
Herpes encephalitis, bilateral temporal lesions, and these lesions have diffusion restriction, diagnostic of herpes encephalitis.
Occipital demyelination في الoccipital.
No.
Cerebellar hemorrhage.
No.
Subarachnoid hemorrhage.
Subarachnoid.
Subarachnoid.
these scans are with contrast. This is a brain with contrast, and
meningitis.
yes, and this is leptomeningeal diagnosis. Infection and the tumor. In the infection, you consider TB and cystoid, and the tumor you consider metastasis. It's very good.
Hydatid cyst.
Yes, hydatid cyst presentation.
Subdural hematoma.
Very good. This is subdural hematoma, not a superior sagittal sinus thrombose, because the superior sagittal sinus is present in the midline image where you can see the brainstem. And this is the superior sagittal sinus thrombose, and this is subdural hematoma. And the hematoma is in the subacute phase, which is not seen in the CT, but appeared by the mass effect. And here you see the bright signal in both T1 and T2.
Glioma.
Yes.
Pix.
Yeah. Yes, this appearance is highly suggestive of a glioma, but this is the MR spectroscopy of the lesion.
Cystic meningioma.
Meningioma.
No, you do not see choline, you do not see creatinine.
Pix.
Alanine elevated.
No, this is abscess.
Yes.
Elevation of the.
If this is one of the rules which should be followed, if you have a lesion like this on MRI, you should consider. But you have the MRS and you do not see the appearance of a tumor, think of infection, and this was a giant tuberculosis. And here you cannot see the tumor peaks, but you see the plate, which is very prominent in inflammatory conditions. Yes, and this is known as meningiomatosis. Meningiomatosis is by definition multiple variable sized meningiomas may be associated with neurofibromatosis, and there are a lot of differential diagnoses for extraaxial lesions, not specifically that they are enhancing, but meningioma, schwannoma, metastasis, and also the cystic lesions, lipoma, arachnoid cyst, and sometimes of the choroid plexus papilloma, and the lymphoma, of course, is one of the extradural lesions. In this patient with HIV, and you see changes in the white matter.
Lymphoma.
No, this is
atrophy.
Dementia.
No,
PML.
Changes in the white matter with atrophic changes, and this is herpes encephalitis. Remember that HIV by itself can cause encephalitis, and the differential diagnosis in these patients will be the BML, as you have said before. Then الوقت خلص مع الأسف الشديد يا دكتور شريف. دكتور شريف.